Thanks, Joe. There are three challenges that you'll see here. They're not new. I think that you all have been practicing in this state certainly longer than I've been running the Medicaid program, and understand the demographics that we face, the chronic health issues that we face in this state, heart disease, diabetes. We rank fairly low across the spectrum. Now, a lot of states rank low, and the states rank low for a long time, so that doesn't explain why we're engaged now in this payment reform effort. It is also true, and this has been true for quite some time, that the health system is difficult to navigate. And the system doesn't encourage doctors and other providers to work as a team. It's important to understand the syntax of this sentence reflects our philosophy in fixing our own house. And in this case, my house is the business of insurance. That's what we do in the Medicaid program. We reimburse and pay for services. We don't provide them. And what we're saying here is that the system, that is the insurance process, the reimbursement and payments, encourages from the patient's point of view, a system that is hard to navigate. From a provider's point of view, we think a system that is hard to navigate and does not work together well. And the third point, which really explains why we're here today, because the first two have been true for so long, that is that health spending is growing unsustainably. That's true at the federal level, at the national level, and is a core driver of the budget deficit that the federal government faces. It is also a state budget issue, as many of you know and have been watching the headlines over the last year or year and a half about the looming and now present Medicaid funding shortfall. But it's also true that private insurance premiums have doubled over the last 10 years, and that this has helped to exacerbate the problem of uninsurance. Because of the profound deficits that we face now, currently in the Medicaid program at the state level and going forward, because Medicaid has grown faster than the economy, faster than the tax base since it was created, we know that trend has to change and that the growth curve has to bend. And it means that something on this next slide is going to have to happen. Medicaid and private insurers believe that paying for results rather than just services is the best option to control costs, but it isn't the only option. We could also be seeking to dramatically reduce payment levels for all providers, and that is what it would take, both this year and in coming years, to keep costs under control simply by reducing payment levels. Now, of course, there are legal restrictions in the Medicaid program, and it would potentially undermine access for us to do this, but it is an option. Another option, foremost for the private insurers, is to pass more costs on to consumers. Premiums, deductibles, co-pays. For the public programs, Medicare and especially Medicaid, there's a limit on how much we can pass on to consumers, in which case we're really passing cost on to taxpayers. A third option is simply to do more of the prior authorization and other interventions that we have traditionally engaged in to try to manage the program. But this really amounts to an intervention in clinical decision, so that the insurer is in some cases standing in the place of a provider in making clinical judgments. But these are the tools we've had in the past. And finally, and most dramatically, if we can't pay our bills, we'll have to shrink the program. And that actually was on the table this year with Level 3 nursing facility services. The growth trend in Medicaid has come down so quickly and so far that we have taken that off the table. Just to repeat, something on this slide will happen, or some combination, and what we would propose and promote and are engaged in is the first. Let's transition to a system that financially rewards value, patient outcomes, and encourages coordinated care. The next slide gives you just a brief overview picture of the activities that Dr. Thompson already described. This is a picture of the payment improvement effort, the initiative as a whole, with its goals for improving health, enhancing the patient experiencing, and experience and to reduce the control or control the cost of care, primarily through reforms of two forms. Joe's described to you on the left, let's start on the right, the episode-based care delivery. That's really what the payment improvement effort has been known for the first year and a half to 2 years. We have 5 and soon 9 episodes in place, but we believe that the greater impact will be through the population-based payment reforms, the medical homes that we're discussing today, and health homes. And you see there the 5 broad aspects of the payment is not the only issue in system reform. Certainly workforce development, health information technology, consumer engagement. We're here focused on getting our house in order as insurers and payers, and that is, of course, the business of payment. 4 principles of the patient-centered medical home, and we will invite you over the course of the next months of implementation and decision-making in the next years of rolling this out. We'll invite you to hold us to these commitments to patient-centered care, focusing on improved quality and experience, empowering, provide support to enable clinical leadership. We understand that providing money may not be enough. Of course, we don't believe we've done that to begin with, supporting a true patient-centered medical home, but money may not be enough. Balance, providing autonomy in the clinical setting as well as guidance. And finally, that it be practical to minimize the requirements and administrative burden. These are our internal goals in designing the patient-centered medical home. And the next slide just describes our aspirations, and Bill will be going through a more concrete set of plans and recommendations here. What do we mean by a patient-centered medical home? A team-based care delivery model led by a primary care provider that comprehensively manages a patient's health needs. What are our aspirations? That providers will be responsible for managing health across their patient panel. That is a new responsibility. Along with that will come a dramatically different and expanded payment model, coordinating and integrating care across multiple multidisciplinary provider teams. This is something we aspire to. Currently, we don't explicitly pay for this. Focusing on prevention and management of chronic disease and putting our money where our mouth is by rewarding clinical focus on those things. Expanded access, referrals to high-value providers, improved wellness and preventive care, use of evidence-informed care. These are the aspirations. We're going to give you next a picture of how we envision the role of the primary care provider in a patient-centered medical home to explain our rationale. Most medical costs occur outside of the office of a primary care physician. We know this, our total reimbursement to primary care physicians or to physicians in general, not just primary care, is just 7 or 8% of the total Medicaid spend. And yet we know that PCPs can guide decisions that impact the 93%, the rest of that spend. It is our goal in establishing a patient-centered medical home to rebalance the relationship between primary care and other medical costs, and in fact to appropriately compensate primary care for the role that we're now going to ask of them. A primary care physician relates to specialists, could relate to community supports, certainly relates to facilities and inpatient emergency rooms, etc. Of course, the foremost relationship in the system to the patient and the family that we cover, and to the ancillary costs and providers, labs, etc. The key problem we face now is that our current payments do not support the role pictured here for primary care providers. We know that we're not paying for this expanded role We know that we're not paying to achieve the aspirations that I went through before, and the tools on the next slide really are the core components that Bill will describe for the patient-centered medical home payment system that we envision. First, and not attributable to the Payment Improvement Initiative, is the Medicaid rate bump, effective this past January 1st, and to be with attached payments for the first time in April. Medicaid rates for primary care are now have been increased to Medicare rates, and that is effective for 2 years, again beginning this past January 1st. There really should be a question mark attached to the next item. There may be a coverage expansion. It is very difficult, though, for us to have a conversation with you in primary care without mentioning the possibility that through private expansion and or Medicaid-funded expansion, there could be as many as 400,000 or more additional covered lives in the state, many of whom would seek an enhanced relationship with primary care. And then the patient-centered medical home reforms, two kinds. Number one, gain sharing. The fundamental reform in patient-centered medical home is to provide a significant upside, financial upside, to share in the savings from effectively managing patient panels' the total cost of care. And the core concept is, if we are asking primary care to play the central role in managing these costs, then we want to attach to that role the financial payoff, or a portion of it. That's for two reasons. One, to make sure that the level of effort we are requesting is the level of effort that we're reimbursing. But the other reason is literally to connect the effort to the responsibility. When those two things are not connected, investments are not made, creativity is less, and we know that costs will be higher if we're asking people to manage but not paying them to share in the payoff from that management. And then a secondary component is monthly member month payments. Thinking of these as support payments for the patient-centered medical home, which would enable upfront investments, ongoing costs in care coordination and practice transformation. You're going to hear in detail about these from Dr. Golden. And finally, just to reiterate the goals that we have here: to reward high-quality care, to encourage clinical effectiveness, to promote early intervention and coordination, reducing complications and their associated costs, and to encourage referrals to high-value downstream providers. None of those, I think, will be new to you as practitioners, to the physicians in your practice. If you are administrative or management staff in a clinic, these are not new goals. What is new is our commitment to pay for them.